Okay. Our first team is exploring the interprofessional healthcare approach to long COVID. Student team 2, the healthcare hikers.
Welcome to our project titled Exploring the Interprofessional Healthcare Approach to Long COVID with myself, Gabe, Valerie, Aya, and Stuart. Our team was composed of 2 osteopathic medical students, 1 allopathic medical student, an accelerated bachelor's of nursing student, and a doctor of pharmacy student, and a special thank you to our helpful facilitators. So a quick background, 87% of patients hospitalized with COVID do develop long COVID, and 35% of people fail to return to their jobs within 14 to 21 days of being diagnosed with COVID. And the chart on the right just shows some quick symptoms of the long COVID symptoms are just old symptoms that didn't resolve and new symptoms due to new complications.
So for our case description, we had Amanda, a 39-year-old female, diagnosed with hypertension while she was hospitalized for COVID for 11 days with ventilator and nasogastric support for 6 days and weaned off and released 5 days after that. She has symptoms of shortness of breath, cough, and migraines that persist into 2023. She's had difficulty balancing work and family responsibilities with these symptoms. She has limited access to care in rural Maine, financial limitations, and her current medications include lisinopril, albuterol, and multivitamins.
So for our methods, our first appointment, we had 2 20-minute sessions in which all providers on the team were able to meet and build rapport with Amanda. We obtained history of her present illness, her medical history, and her priorities. And we also gave her some suggestions for headaches and for her feet issues that she could try before our next meeting. Our next meeting with her was also 2 20-minute sessions with Amanda, and this time her husband Mo was present. We followed up with the previous suggestions to see if they worked. We gathered more information about her illness to see if there were any changes from the last visit. And we worked on her SES difficulties, counseled her on her current meds, including lisinopril, and possible new medications for headaches, like triptan.
For our takeaways, we found that if we had access to a social worker and physical therapist, we would have improved patient outcomes through knowledge and access to different services. Unfortunately, we didn't have those on our team. Determining patient goals and helping them achieve those goals is very important in the setting of long-term illnesses. We found telehealth visits are essential for access to care in rural areas. Our patient lived in a rural area, but they present with unique challenges like obtaining labs and vitals. And we also found that having a spouse or other family member present during a telehealth appointment can alter the dynamic and have both positive and negative effects. These are our references. I'll now open it up to questions. Thank you.
Thank you, team, for a wonderful presentation. My name's Emily Dormwitzer. I'm going to be the facilitator for this breakout session, and I'm going to open it up and give everybody that awkward pause of silence. Does anybody have questions for the team? I see some pharmacy students, and I'm not afraid to call on you. But Karen, do you have your hand up?
After 3 years of Zoom, you think you'd have a handle on this. So Stuart and others, you referenced that using telehealth has both benefits and, drawbacks when you're thinking about inclusion of the family. Could you say a little bit more about that? I think what's interesting to me about this case is not only all that we're learning about long COVID, but we're also learning about new intervention strategies such as telehealth. And so can you share with me some of what you learned was helpful and not helpful with telehealth and inclusion of families with the patient?
Yeah, I think having a family member present in a telehealth visit can be beneficial just to get another point of view and see how it's affecting the family. In this case, she was having really bad headaches. She couldn't spend time with her family or really do anything. She was pretty debilitating. So that was helpful, but I guess it can kind of get derailed with the line of questioning. It's kind of hard to steer an interview, like with motivational interviewing. So having someone interjecting or interrupting can kind of be bad for that. Yeah.
So part of developing that rapport and being able, with your example of motivational interviewing, it's hard to execute that if you've got a third party or more interjecting and taking the conversation in a different direction.
Yeah.
Yeah. Well, I think it also illustrates how we need to practice on the education side, managing those types of conversations, because I do think that as telehealth becomes more ubiquitous and we use it more and more, we're going to have less control of those environmental interruptions that, you know, may not support what we initially thought was going to happen in the interview.
Does anybody else have a question? I have one for the team. Just I think reflecting on maybe the previous question, one of the things as a previous IPTI facilitator I find is that when you hit a challenge with the patient, the value of having somebody else from either a different discipline or a different perspective can be really helpful in trying to tackle whatever challenge is in front of you. So I'm wondering if anyone from the team has any reflections on what maybe another profession brought to the experience that you weren't expecting or that ended up being helpful in that process. I saw you might want to respond.
Yeah, so our team was kind of weird because we had 3 medical students and a physical therapist and a nursing student. So we had a lot of like the, I guess, the medical background on the team, but we didn't have much of the social work background or the physical therapist background. So for us, it was definitely valuable to kind of, especially with the pharmacist on our team, to kind of bounce ideas back and forth and talking about her different medications and like lisinopril, how that might be affecting her. But we would have loved to have a social worker on our team to help us address those SES problems that were coming up, because that was a big part of her case as well. So I think that would have been a really great addition to our team and something that we were lacking. But I hope that other teams who did have that interaction with their social worker were probably able to benefit more from being able to learn from them and incorporate them in Amanda's care as well.
I think it really highlights sometimes when we're out in practice, we don't get a chance to choose our teams exactly. And you can this really highlights how having a really unbalanced team can actually like highlight what might be lacking in terms of helping to solve the patient's problems at hand, which is really important, I think, for all of us to be able to recognize like when to refer and when to ask for additional resources and those sorts of things. Any other questions? Folks from maybe a different profession have any curiosity about maybe some of the interventions they suggested?
We have just 1 minute left, but I'm curious if you feel like there was a really good understanding of how you managed your time with the patient and how that changed between the first and the second encounters.
Yeah, I can jump in on that. So the first encounter with Amanda, so our idea was to go in there and we had a whole plan of what we were going to ask her and stuff, but obviously when we got in there, we found that the conversations kind of derailed. She went on tangents a lot. So we had to kind of throw out our entire plan and re-decide what we were going to do for our second 20-minute session with her. So we came in with a plan, but I mean, it really depends on where the conversation takes you and what the patient's priorities are, is what we found really determines on what the next appointment is going to be like.
Great flexibility. Thank you. Well done, team. We're going to move on to our next presentation.
Hi, everyone. I am Abigail Palin. I'm a second-year medical student. I was part of Team 4 during IPTI, the Compassionate Communicators, along with my 2 colleagues. And for our project, we wanted to focus on the specific learnings that we took out of IPTI rather than its value as an entire entity as a learning experience. So as you know, IPTI is comprised of 2 major sessions, each of which has a planning portion, interview portion, debrief portion, and a second interview. Our team had the following occupations: occupational therapy, physical therapy, osteopathic medicine, pharmacy, dental hygiene, podiatry, and social work. And this is the approach that we took.
So hi, I'm Stephanie Burns. I'm a first-year occupational therapy student. First, we had to decide which team members were going into the interview slots with meeting Amanda and then learning about her concerns. And then after that, we had to adjust her concerns. And then the third one was also having limited time dedicated to each concern, which was kind of a struggle for us, and then having multiple interviews that were necessary to adjust the concerns that she stated. And then with that, we had to make some revisions. So first, we had to establish our priorities of her care. So we started broad initially, and then we had to explore the options and rank her concerns in order of urgency. And then we had to develop a collaborative team plan to refer Amanda and her colleagues to the necessary colleagues as indicated. So as we followed up with her routines, we reevaluated and revised priority concerns continuously and made progress throughout the treatment sessions.
Hi, I'm Andy. I'm a junior dental hygiene student. Our main discussion during the IPTI process was extrapolating lessons learned from IPTI to practice, and those should be done mindfully of our status as students with limited knowledge and clinical expertise. Some of our conclusions throughout this was that clear and early identification of a care manager facilitated effective communication, promoted understanding, and reduced overwhelm. Complaints addressed one by one in a risk stratified way allowed for maximal progress, follow-up, and closure. And although all decision-making remained interprofessional, the best patient care was delivered on a one-to-one basis.
Thank you, compassionate caregivers.
Wonderful. I think my takeaway here is perhaps the theme of flexibility. I'm wondering if anyone on the team might want to expand a little bit on, it sounds like you guys noted a lot of needing to step back and redesign your approach to certain things. What surprised you the most about that first interaction with your patient?
I can speak to that one. I think we struggled with a lack of a cohesive plan going in. We were trying to leave things very, very open, but that actually ended up working against us, I think, because in that sense, we were trying to pursue so many different avenues all at once, when in reality, I think we would have benefited from pursuing one avenue and then adjusting as necessary rather than casting such a broad net to begin with. We found that our later approach, which was a little bit more pointed and following patient advocated priorities, that was much more effective rather than having our own agenda, trying to incorporate all of the different professions simultaneously. That became a lot to juggle and manage time-wise at the same time.
Wonderful. Mike, I see you have a hand raised.
I do. My name is Mike Sheldon. I'm the Associate Provost for Academic Affairs. I'm going to ask you a question that maybe a little bit of an extension of what your project was about. So I hope you don't view it as unfair. And I'm just really interested in your thoughts about this. How do you think artificial intelligence will help you in the future? There's a lot of publications coming out right now. It's all over the media and so forth, but there's a lot of applications that are being written about in healthcare, algorithms to help drive decision-making and so forth. And I'm really curious if any of you have given that any thought and how that may integrate into sort of your team-based work that you're doing.
I can speak to that again, I guess. One of the obstacles that we came up against kind of in our later interviews was beginning to concern ourselves with Amanda's mental health. And I think if we had been able to risk stratify that in the very beginning through some sort of algorithm that, predetermined and predicted her risk for suicidal ideation or self-harm, anything like that, that would have been a really great jumping off point, and it would have saved us so much time behind the scenes in the planning phases and actually during our interviews. So it would have allowed us to pick the most pertinent path right off the bat, I think.
Very thoughtful answer and a very, I know you weren't prepared for that one, probably.
Does anybody else have any curiosity?
I see Frank has his hand raised.
Oh, Frank. Hi.
Hi there. Great presentation. And I was wondering what you meant by the term reduce overwhelm. Was that based on you sense that the patient was overwhelmed?
I think that was a little bit of both. We didn't want the patient to feel overwhelmed with all of our different viewpoints and all of our different questions. But in the breakout rooms, we didn't want the team to feel overwhelmed with same thing, all the different viewpoints of everything. Like for me, I'm a dental hygiene major, and then we had, well, they were all different. But for example, social work and dental hygiene, I don't think they could be any more different. So kind of putting in our 2 cents to everything could get overwhelming at times because you just had so many different viewpoints on everything at once. And you didn't want overwhelming questions to go into the interview and then overwhelm Amanda. So I think that's what we meant by that.
Thank you.
That's a great question because I think it highlights, as you answered that, Andy, how we all bring different lenses to these patients. And when you work interprofessionally, I think one of the best things you recognize is everybody's got a lens, and it's picking which lens you might need at any given time that's best for that patient, and how to share lenses and how to trade them back and forth amongst each other. So I hope that's an experience you guys take away. I see Shelley has her hand up.
For change. So one of the myths of interprofessional education and practice is that everybody has to be in the room at the same time and interacting with the patient. And it sounds like you really did a lovely job of processing, you know, it was a little bumpy, but processing the fact that you could work as a team, but interact with the patient singly, that worked best for the patient. So I'd love to hear just a little bit more about how you processed and came to that, because it was really a beautiful outcome.
I would say we went in, we had like a general plan. Obviously, our main goal was to help Amanda the best we could. But overall, I think we went into it kind of not knowing exactly what we were going to get out of the first interview. And that one was a little bit jumbled up per se, because we had a lot of questions, a lot of different people in there asking questions to see what the main focus should be. And then after that first interview, we took her main concerns and broke it down from there. And we didn't have everyone in the room at once. We put 1 or 2 people in just to focus on those main concerns that she had.
Great approach. Thank you so much, team. We're going to move on to the next presentation. Well done. Next up, we have student team 6, the balance beans.
1.
Our project title is Long COVID Using Interprofessional Team Immersion Treatment, and our team's name was the Balance Beans. Our team was made up of student physicians, nurses, physical therapists, and pharmacists. We would like to say a special thank you to our facilitators. Long COVID is a syndrome characterized by a wide range of health problems, including persistent headache, brain fog, fatigue, dyspnea, muscle weakness, and depression, with headache being one of the most disabling symptoms. A longitudinal prospective study out of UCLA found 30% of people treated for COVID-19 developed long COVID. The vast number of people developing this condition emphasizes the dire need for treatment approaches that are accessible to all affected individuals. However, treatment for Maine residents affected with long COVID can be especially challenging due to geographical distances between the patient and their health care facility. Telehealth may help overcome these challenges, as well as utilizing a multidisciplinary treatment approach.
Amanda was hospitalized in November of 2021 due to COVID. She was in the ICU for 11 days with 6 days on a ventilator. In 2023, she still had lingering symptoms of fatigue, brain fog, appetite loss, shortness of breath, and most prominently, her debilitating migraines. These symptoms have harmed her well-being, her job, and has limited the quality time she could spend with her family. Living in rural Maine has limited Amanda's access to medical care due to travel and healthcare costs.
Our methods for this study included an interprofessional team immersion orientation, a day in which we learned the rules of the simulation. We met with our team, got to know each other, and got introduced to Amanda's backstory, history, and current symptoms. Over the course of a few weeks, we had 2 different appointment dates via Zoom. Each had 2 20-minute sessions with Amanda and included a time for pre-brief and debrief amongst the team members. And each of us had individual opportunities to communicate with Amanda and to practice our interprofessional communication skills amongst individual team members.
During the first appointment, each provider was able to meet with Amanda and build rapport and get a better understanding of what concerns she had since her COVID diagnosis. During this appointment, we gathered medical history and a general health intake. Suggestions were given by PT to help with back pain, and conversations about medication treatments were discussed. During her second appointment, the physician and the pharmacist met with Amanda and Mo together, and medication counseling resulted in Imitrex being recommended for migraine treatment.
We learned via talking to Amanda and Mo that we could have sent 1 or 2 people in to gather patient information on the first meeting. For the second meeting, this is when we could have counseled. We learned that through all of the discussion with Amanda, that her goals were to spend more time with her kids and get back to work. Debilitating headache due to long COVID was preventing her from reaching her goals. We learned that time management is a key component of telehealth visits and would have managed our time differently, especially on the first meeting. Finally, we learned that having an understanding of the roles of other providers allows for good continuity of care and reduced repeated assessments.
Great
Thank
presentation.
you, team. Wonderful. Well, your last takeaway point is one that I thought I'd start a question on and then ask if others have a question. But you mentioned that collaborating with each other reduced the need for repeated assessments. And so one of the things I think is a great takeaway from IPTI is learning how folks have shared roles, not just what differentiates your profession from each other, but how you can often do the same thing and learn to trust each other and your abilities. And so I'm wondering if the team might speak to some of those experiences that you might have had, and what did you learn from each other and the abilities that you share?
Absolutely. I think overall I was really surprised with the amount of overlap that each profession had when they were initially meeting with a patient and doing their intake. And I think it's very easy to become siloed. And I think that this experience really helped us realize that we can prevent a lot of this overlap, which can be cumbersome for the patient, if you have a thoughtful meeting beforehand as a team to figure out, okay, who can ask these questions so we're not duplicating questions. So I think that was a huge takeaway that I personally got from this experience.
Yes, I can speak on that as well. I think I actually wasn't able to attend the first meeting. So after watching it back, I was able to watch the video back and take notes. And it was interesting because you could tell that the patient was getting a little annoyed by trying to answer the same questions over and over. So it definitely did help alleviate some of that in the second meeting. And it also helped, I think maybe next time if we did it again, it would be helpful to just kind of go over exactly what we ask in an intake. Because I think as a nurse, I just think I, get the full assessment, but I don't know exactly what everybody else needs to grab. So I think that would be really helpful next time.
Great. Carmela?
Yeah, I really enjoyed seeing, like you were mentioning before, just like how there is that overlap between the professions. I thought that was just incredible. It was also just nice to get everyone's perspective on it, and then like seeing them interact with the patient as well was super helpful, and just to see how they would like maybe word something differently, or just simple stuff like that even was really good to see.
Wonderful. What other questions do folks have? I've got lots, so I could just keep asking you all. So I guess I'm interested, you talked about a pharmacist and a physician going in the second session, and I'm interested to hear a little bit more about how that collaborative experience took place in terms of making a medication recommendation and counseling, and how did you guys divide roles, because that is often a duplicated experience on both the pharmacy side and maybe the doctor's visit side of things. So talk to me a little bit about that.
Yeah, that was Terry and myself. So like on the second visit, we went in and we were chatting with Amanda and Mo. I don't know, Terry, if you wanna.
Yeah, I think the hardest part was kind of because we're all students learning as we go, especially with an experience like this with telehealth. It was kind of difficult, but kind of learn the roles. I think we just kind of bounced off of ideas, like you'd make a recommendation and then the pharmacists tend to know a little bit more about medication access and price and things like that. So I think as a physician, you kind of know what drug classes there are, but there's so many different individual drugs that you can choose from that sometimes there's a lot of wiggle room in what you actually choose when it comes to generic, name brand, or even which specific medication. So I think that's what pharmacists are really good for, is knowing the details.
Wonderful. And would you guys have liked anyone else on your team? What might have been lacking?
We did not have a specific social work student, but luckily one of our facilitators, she's I think she was working toward her doctorate in social work. I can't remember exactly what how far she was, but she was spectacular when we had a couple of questions. But we kind of originally came up with a plan before we talked to her about it. Just, you know, wanted to make a recommendation to social work to try to meet the patient where she's at, because she did have many trepidations for that. She was very worried about meeting with social work. So it was at least nice to say, we'll, you know, have someone reach out to you. So
Thank you all. I think we're about to transition to the next presentation.
Yes, well done, Balanced Beans. For our fourth presentation, we have student team 8, the healthcare hamsters.
Hi, my name is Kim DeCarlo, and I am in the Master of Social Work program.
Hi, my name is Sailor, and I'm in the Doctor of Physical Therapy program.
Hi, my name is Victoria, and I'm in the Accelerated Nursing program.
Hi everyone, my name is Annika, and I'm a junior in the dental hygiene program here at UNE. So for this spring's poster session, we decided to focus on the concept of establishing virtual continuity of care for a patient with long COVID using a multidisciplinary approach. Our group was comprised of students from both UNE and Rosalind Franklin, where we had a diverse array of professions being represented, such as osteopathic medicine, pharmacy, allopathic medicine.
And our goal was to take care of Amanda, who was a simulated patient played by a real actor. And Amanda was 39 years old and suffering from symptoms of long COVID after having COVID and being hospitalized for an extended period of time in the ICU. She is hopeful to get back to her daily routine, her life with her family, but she lives in a rural area and doesn't often have consistent access to medical management.
We believe that meeting our patient in an interprofessional setting was beneficial for meeting the patient's concerns about the financial burden of care, a lack of time to dedicate to appointments, and about receiving inconsistent care. We also believe that an interprofessional telehealth approach allowed us to provide care to an individual in a rural setting who may lack access, and for management of long COVID symptoms, which the research is still catching up with.
This slide looks at the interprofessional connections we shared in terms of each of our professional code of ethics. As you can see from the sections broken down by each of our professions, we share similarities within our ethics that focus on the humanness of those we provide care for and what we keep in mind while providing that care. This supports the collaborative approach we took as we are rooted in common themes.
And we just wanted to thank our peer facilitator, Anik, and our staff facilitators, Frank Brooks from social work and Chris Bates-Withers from PA, for helping us, for steering us through this interprofessional team immersion experience. And thank you for everyone else who has listened to our presentation.
What a great presentation. Thank you guys. I have one very important question and then we'll get to the real stuff, but which one of you got to draw the stethoscope on the hamster, or did it come like that? I thought that was great. My big question that I have for you all is, I'm so thrilled to see your slide about shared values, because one of the major competencies in interprofessional education is shared values and ethics. And I'm wondering, how did you guys come up with that slide, and what was your sharing process of figuring out what your values were? Because that is just such an important part of fundamentals of building a team, is knowing that you all have a shared place of values. So I'm really interested to hear about that.
So that was mostly Kim's idea. Kim was the one who, from social work, decided that she was going to look over every single one of our codes of ethics per program and find common similarities between all of them and then listen together. And then the more she looked, the more we all realized that wow, even though we're different programs, we all share a very common theme, and that she was able to put it together on that slide. So, it was kind of a bonding moment.
Yay.
Yeah, and I think we also saw a bit of that too when we were talking and putting the poster together. And also during our debrief sessions, we're we're all kind of on the same page here. We do kind of all have the same goals, even though we're really looking at things through a different lens.
Mm-hmm. Mm-hmm. I'm wondering, if you guys all had to pick which value you think is most important to your profession, what might you, if you had to pick one value, what would you put out there?
For my profession, which is nursing, I would probably pick advocacy, patient advocacy. That's, I think, the most important thing. And I'm not going to speak for the other professions because I know that every other profession, including especially social work, which Kim is from, does a lot of advocating for patients. But I feel that personally, to me at least, that is our most important value.
Sure. Say what?
Yeah, that's a really good question. I don't know if I could just pick one. I think advocacy is great as well. And yeah, I'll leave it at that for now.
Wonderful. And Annika?
Yeah, I was just going to say, I think it's really important that the patient knows that they can trust us throughout their whole process. And especially in dental hygiene, a lot of patients are embarrassed and don't visit the office regularly, or, there's always different things. So just forming that connection with them, I think, is really important.
Anybody else have any questions from the audience?
Thank you. Yay, happy hamsters. Great job. I wanted to ask you a question about, yes, you came together around the Code of Ethics and Values. Was there any tension that you had to work through, or were there areas of concern that any of you had that you thought might cause a reduction in team approach?
I personally don't recall any tension, but the only thing that I thought that might reduce the cohesiveness was that we were all from different schools and we'd never met each other before. So it's, kind of all being thrown together and saying, here, work on this. We don't really know if we have anything in common other than our professions. So that was the only, obstacle that I saw.
Yeah, jumping off of that, I would say it was I think just like any new team, kind of awkward and hard to know who was gonna kind of emerge and get the organization process started. And I think we eventually decided to have a point person, which was Kim, and she was kind of the cohesive, continuous link throughout all the visits that we had. And once we kind of decided that we could all play around her, and then it made the transitions really smooth and easy. But before, we were kind of I don't know, should we just throw out 3 random professions at a time and see what sticks, or what do we do? And I think maybe that was more of a point of just not knowing.
Yeah, I was also curious about this galvanizing around the ethics, if that was done more in your after action review as you were creating this poster presentation, or if it was integral in the work. If it was done after the experience, how do you think it would have played a factor if it was done early on in the formation of your interprofessional team?
I think if it had been discussed earlier on, it may have broken down some of the, the social barriers between us, since, we didn't really know each other all very well. But I think doing it afterward was also really important, because that's when we ended up doing it. That's when we ended up reflecting on, hey, what was motivating you during this? And then finding out, oh, we all have a very similar code of ethics.
You guys have really highlighted such an important part of team dynamics, which is not only coming at your problem from a place of shared values, but also recognizing that there needs to be a leader, but that's not necessarily the person that's doing everything. And so I'm wondering, how did it sounds like Kim became your point person, but how did you guys help her in making sure that things got done, and what was kind of your team dynamics in that role?
So it wasn't so much picking a leader as someone that the patient could have with them, so that the patient could depend on. Who could we, for lack of a better term, we kind of had to choose a case manager, someone who can coordinate with every profession, and who the patient can have with them at all times, so they're not constantly being flung around in between different professions. So that was helpful, but I wouldn't necessarily call it electing a leader, but it is helpful to have one person, that we all can funnel everything through before it reaches the patient.
So shared, sort of much more of a shared leadership model, but the patient doesn't necessarily see that. The patient sees a person, which I think is
yes.
We're constantly trying to put the patient at the center of everything. which sometimes makes it harder for us in the background to kind of manage and plan. But it sounds like you guys really did an excellent job of keeping the patient's goals in mind and making sure that the patient felt safe with your team and meeting all their needs. So well done. On to our last one, I think.
Yeah, this is always the fastest hour of the semester. Well done, team. And we have the collaborative Cape Buffaloes with Husna from Pharmacy, Team 3.
My name is Husna. I'm from the pharmacy. I'm in P2. Today we're going to discuss regarding interprofessional collaboration to manage long-haul COVID patient. Long-haul COVID are a wide range of new, returning, or ongoing health problems that people experience after experiencing COVID-19. In our case, Amanda, 39 years old, was hospitalized for 11 days after being diagnosed with COVID. She has been experiencing since then symptoms including decrease in her appetite and nutrition intake due to loss of taste and smell. She has been experiencing also headaches, fatigue, anxiety, and depression. We had 2 appointments with Amanda for 20 minutes each. The first one was only Amanda, in where we have to gather all the information from Amanda and listen to her concerns. And also we had to plan for a treatment goals. For the second one was Amanda with her husband, in which we engaged Amanda and her husband in the treatment plan. We discussed the treatment and answered the questions that she had. For the clinical interventions, we suggested monitor blood pressure, change albuterol to Symbicort, decrease headache, to decrease the headaches that she had, which was one of the side effects of albuterol. We suggested family therapy. For headaches, Amanda didn't want chemical-based medication. She was going for plant medication, so we suggested Feverfew or Butterbur. Also, we suggested to avoid non-steroidal anti-inflammatory because of her hypertension. For the lifestyle, we suggested to improve her sleeping, diet, drink a lot of water, exercise, sit in a quiet room using compression sock. For the interview with Amanda in telehealth, we used motivational interview in which we had to build a patient rapport through active listening. We used open-ended questions, respect the patient current state and express empathy, support the patient in possibility of positive outcome, support the whole family and build trust, listen to Amanda and achieve best outcome without making Amanda uncomfortable, also build self-confidence. I would like to thank the UNECC. Also, I would like to thank our faculty facilitator, Valerie, also peer facilitator, Ostasia. Also, I would like to thank our wonderful actors who gave us the opportunity to immerse ourselves into a real-time telehealth. Thank you.
Thank you, Husna, for such a great presentation. It seems like you had to cover it all. Might you tell me who else was on your team and what did you learn from those other folks there?
So I was with a nurse, I was with a PT. Also, we had a social worker, but she didn't come in, so we had to, like, every time refer to the social worker. And other thing I've learned from them is just our health program overlaps, and that's what I learned, that we when we are together, when we put everything together, we can complete each other.
Wonderful. One of the things that struck me, maybe from the pharmacy side of things, and since I know you're on the pharmacy side, was that the patient did not want medical-based care or chemical-based care. And so I wonder, that's what type of a challenge that might have been to the team, and how did the team manage that?
Oh, I didn't hear the question.
So the patient said she didn't want chemical-based care for her headaches. And so I'm interested as to how the team responded to that, and how did you come up with your recommendations?
Because our telehealth was based patient. We had to listen to the patient and give her the outcome that she wanted. So we had to do some research on medication for headaches. and we came up with the 2 medication, but about all feverfew, and they were going also for that outcome, and because all of us, we wanted the best outcome for the patient, so we were okay with the plan.
Mhm. Were there any parts that the other professions that maybe you specifically thought was a major contribution from another profession that you could expand upon?
I think every professional contributed, and if we had a social worker, that would be great, because Amanda had a lot of financial burden, and we wanted someone to connect her with all the help that she wanted.
Wonderful. Does anybody else have some questions?
I do. I'm curious if you would recommend this experience to another student in your program or even in another program, and what you might say are the benefits and challenges of participating in this kind of immersion.
Oh yes, I will recommend this experience to other pharmacy students, and the benefit that I have learned to work with other professionals and to listen to them and to know that I don't know everything. I have to also to contact my fellow professional health, and also the disadvantage. I didn't see any advantage in it. I saw only I didn't see any disadvantage. I only saw advantages in it.
I guess I'll ask you one more, which is, was there anything from the pharmacy side that you felt like you hadn't learned quite a bit about, that you would be interested in learning more about, that came about from this case?
I guess because I'm a P2, we are in ID, infection diseases, so we are learning COVID, and that's where it was a little bit hard for me, because it was before I learned more about COVID and long haul COVID, but I don't think there is anything I would say that we have to learn more in pharmacy, because we learn medicine and natural medicine and everything, and that's what I used my my knowledge that I learned in pharmacy on this case.
Wonderful. Well, thank you for being the solo presenter for your team. That is strong work. Well done.
Thank you.
This is a really rich discussion. Thank you for all of the knowledge sharing.